Hey Doc, it's Nick. Now, here's your patient. You were inquiring about a Carrierre appliance. Um, Before we start talking about solutions, let's do a little bit of diagnosis. Um, Obviously, severe deep bite here. First question I always ask is is this deep bite a result of wear, attrition, or anything like that? Obviously not. I believe the patient's a little bit younger and hasn't exhibited any wear. This looks more like a skeletal class 2 situation. Although this is not a cephalometric radiograph, you can get a pretty good sense that she's skeletally class 2 just based on this alone. When we have skeletal situations, the conversation should involve orthognathic surgery, although I don't think this case is severe enough to warrant that. It's worth considering. So let's just assume the patient doesn't want to do it, as most patients don't want to do orthognathic surgery, especially for maybe a mild case. We have to keep in mind that our ability to create perfection in a dental situation is limited. So one thing I would just let the patient know is that I can straighten the teeth, but I can only straighten them as much as the bone will allow me to straighten them. So something to keep in mind when we have a conversation with this patient, that the outcome is probably not going to be perfect. So aligning expectations with patients is very important. So that's number one. Number two, what's the dental sagittal orientation? As you had said, she's class 2 on the left side. It might be worth going through the exercise. Anytime I see a sagittal discrepancy, I always count the teeth to make sure that there's no tooth discrepancy. And I did that, and there's all the teeth are present. But sometimes you're missing a incisor on the lower. Sometimes you're missing a premolar. There's all kinds of different reasons why these particular situations show up. It's good to get the proper diagnosis before we start thinking about the treatment, which I know you're very good at. So coming back to the sagittal discrepancy, here we have a class 2 molar relationship. In the orthodontic community, they have a few shorthand ways of describing class 2 relationships with the molars. This would be called an end-on class 2. End-on because the molars are on top of each other, as opposed to a full cusp class 2 would be where this cusp tip here on the upper 6 is what they call it, or the upper first molar, is in this embrasure here, full cusp class 2. In general, this is about a 3 millimeter discrepancy. End-ons, full cusp are more like 5 or 6 millimeters. So it just gives you an idea of how much sagittal discrepancy there is. Of note, there's a crossbite here. It looks easy to fix. That might be more challenging, but based on the number of trays this patient's going to need, I think with a good button here, we can get that crossbite resolved. Again, deep bite, we have a tilting of the maxillary incisors. Some root form attachments will be very helpful here. The twin attachments to give us some root torque to make sure that we get this midline appropriately positioned as we are intruding these teeth back to this level here. We have the canines as a reference point on how far we want to intrude these teeth, but the bulk and lion's share of the intrusion is going to come from the lower teeth. Looking at the right side, canine, slightly class 2, molar. The molars look class 1, but this one doesn't. That gives me a clue that maybe this tooth is actually rotated. One of the solutions that orthodontists use to solve class 2 situations is to rotate the first molar, upper first molar, or the upper 6s. So you can imagine, based on the rhomboid shape of the upper first molars, that if we rotate it, what would be called mesial out. Mesial out is this counterclockwise rotation. We're actually going to decrease the arch length, because this point here to this point here, I'm drawing a line, access line at this angle here. If we get that line in the line of the arch form, we're actually going to use up less arch space. Because we have a class 2 situation where there's excessive overjet and overbite, but more of the sagittal conversation is where we're focusing our efforts right now. If we rotate this tooth, we actually decrease the amount of arch space that we have. And we can also do the same here. We take advantage of the rhomboid shape of the upper molars to decrease arch length is one of the techniques that orthodontists use to help address sagittal discrepancies. Coming over here, the left side, look how much arch length this tooth is taking up. So if we rotate this tooth mesial out, you can imagine we're going to gain at least a millimeter or two simply based on the fact we're going to rotate that tooth. That's the whole idea of the Carrierre appliance, or it's one of the major aspects of the Carrierre appliance is the fact that the cleat is not fixed on the upper first molar. It's fixed on the canine, not on the molar. That retrusive force or distalizing force of the elastics with the Carrierre also causes mesial out rotation. Excuse me for a second. Apparently it's time to get up. All right, so mesial out rotation of the upper sixes decreases the arch length. You could imagine that we're going to gain quite a bit here, and the Carrierre will help us with that. If we don't use the Carrierre based on patient preference, then we're going to want to put a very specific button on this tooth to cause that rotation or to help encourage that rotation. And we could talk about that, but I think this patient really needs to be on board with a rather comprehensive two-year orthodontic treatment plan. If they want it faster, it probably would be a little faster with braces. The jury's still out, at least in my world, on whether or not leveling lower curves of SPI is better with braces or not. I've definitely addressed cases like this with Invisalign, but they take longer. And there's some other techniques and methodologies that we're going to want to take advantage of to help us get to the other side of it. But again, let's continue with the diagnosis. So class 2, these molars are rotated, which is good because we can rotate them to decrease the arch length. Bolt-in analysis is often very helpful. So coming over here, and this is one of those situations where it's a little bit confusing because the mandibular excess. Let me take a step back. So the Bolt-in analysis says, what is the ratio of the widths of the teeth on the upper versus the lower compared to normal standard deviations or normal distributions amongst the population? So it's a way of just saying, do we have a tooth size discrepancy between the arches? One of the beautiful tools that ClinCheck offers us is this Bolt-in analysis without having to measure ourselves in person. Mandibular excess means that there's more on the lower. Maxillary excess means there's more on the upper. 3 to 3 means canine to canine. There's actually slightly more tooth width to the lower teeth between those teeth. But then if you bring in the premolars and the molar, you actually have a maxillary excess. So what's interesting here is the excess that's created on the maxilla is primarily isolated to this posterior segment here. That's helpful because if we do a bunch of IPR in the anterior, we're actually not necessarily helping the situation. So using the Bolt-in analysis to truly dial in where the problem is super helpful. What I don't know, and I've tried to find the answer, is this number the tooth width in this dimension? In other words, in its current position within the arch, or is it the ideal position of the tooth itself? My gut tells me that it's from here to here. And one way to assess that is we come over and we look at the actual measurements here. So number 3 and number 14 are relatively the same distance or the same width, which is what one would expect. based on symmetry. So I'm sharing this with you because I don't know if rotation alone is going to improve this maxillary excess versus there's just too much tooth structure, and we need to consider removing that tooth structure to align these arches better. Again, the problem is a skeletal problem, not a dental problem. With that said, there is a dental component to it because we have a significant excess here. If we have a very minimal bolt-in discrepancy, but we look here and we see this orthognathic discrepancy, then we know it's 100% a skeletal problem. But oftentimes it's a mixture of the two. So we have to know what the problem is so that we apply the right recommendation to the patient. Yes, orthognathic surgery is the right one. Few patients, if any, go with that. Therefore, anything we do to the teeth is what orthodontists call camouflage treatment. So this is a camouflage treatment case if we're going to be using dental-only solutions to solve an orthognathic surgery problem. So the bolt-in analysis gives us a line of sight into that idea. So as far as diagnosis goes, let's continue going to the lower curve of Spee. Class 2 cases are, they often lend themselves to this exaggerated curve of Spee because of the sagittal discrepancy. The lower teeth sit farther back in the arch and therefore have more vertical room to run until they run into opposition. So whenever you see a case like this, you almost always can say this is a class 2 patient without ever looking at the upper arch, something that we've talked about in the past. In order to intrude that, that's a very significant intrusion. With that said, this might be more predictable, not because Invisalign is super wonderful at intrusion, but the teeth actually need to come forward. So ask yourself, what vector of force and what direction do these teeth need to go in order to align? When you look at this view, you think to yourself, well, I need to intrude those teeth. And if we had to intrude 100% intrusion of these teeth in order to align the lower occlusal plane, I don't think Invisalign would do that alone. But this is a class 2 case where these lower teeth are retroclined. Simply pushing them forward will create what's called a relative intrusion. So if we picture this canine tip here, if we push this way, this tooth is actually going to tilt down, and when it tilts down, it's relatively intruded. The tip of the root may not be intruded, but the tip of the incisal edge will be in a more apical position, which is what we're looking to do. Not to mention, we're improving the sagittal position here. But here's the risk, and it probably is jumping out at you already. When we interiorize or buccalize teeth, we always have to ask the question, how is the periodontium in that situation, so that we don't create or induce undue recession and or bone loss. It's true that if we go slower, the periodontium does better. It's very possible that this patient has enough of an alveolus here to receive that force. But this patient is at higher risk for having recession down here if we truly are going to bring these teeth anteriorly compared to where they are now. What do? You have a conversation with the patient about the risk. This might be one, especially if the patient has a thin biotype, that I would refer to the periodontist and just have them get their eyes on it and say, look, we're looking to bring these teeth come over to the tooth movement assessment. Where is it? Tables, tooth movement tables. So I come over here and I want to let the periodontist know how much I plan on buccalizing these teeth. I come down here in the chart. It looks like 3 millimeters, 24 and 25. So just write on your referral form, I plan on buccalizing these teeth by 3 to 4 millimeters. Please provide insight on the periodontal status. And if you do recommend treatment, you recommend it before or after orthodontic care. So that's a common conversation that will be had between an orthodontist and a periodontist that we can have too. Bringing the periodontist in also takes the stress off your back that if there is recession here, it was discussed with the patient and a specialist was looped in. I do have one case that this happened. I ended up paying for a free gingival graft for a patient that I did not properly arm early on. So hopefully I helped you avoid a bullet there with a case like this. The properly informed patient that knows this might be possible is all you really need to do. At the end of the day, I firmly believe that intruding and buccalizing these lower incisors is far more biomechanically favorable than her current situation. But if you create a problem that wasn't there before, that's a much harder hill to climb than a properly educated patient. So that's that. As far as intruding these teeth, let's ask the question, how far are we going down? So intrusion, extrusion. I don't really see a whole lot of intrusion here. 3 millimeters is a lot, but not out of the realm of possibilities with clear aligner therapy. So the intrusion actually doesn't even start till tray 14. So it looks like what they're doing in the beginning is just creating space and buccalizing forward before the intrusion starts. Ideally, I like intrusion to start sooner, but Invisalign knows that you can only apply forces in so many vectors at the same time. I would build in more intrusion in these early trays. Because this is a purely buccalizing motion. I feel like you're at higher risk for increasing a periodontal problem. So I would just have the lab technician build in maybe 25% of the intrusion from tray 1 to 15. So in other words, this intrusion here, let's say is 3 millimeters, let's say 33%. Have them do a millimeter of that intrusion during trays 1 and 15 as they're being buccalized. So we're going to be pushing down at the same time as pushing forward. As a result, the patient has to be very compliant with wearing the trays. If we're going to be adding vectors of force to the trays, I might lean on more days. I might lean on more patient compliance. You kind of have to build that in. The more complex the movements, the longer the time, and the more compliant the patient has to be. You just build that in your conversations with the patients. The other aspect of leveling the curve of speed is something called meow mechanics, which comes out of the world of orthodontics, where they use their edge wire brackets in a way to extrude the lower 5s and 6s to help level the curve of speed. And that does two things. One, extruding these does help to improve the overjet through relative, I don't want to call that relative intrusion, but if we extrude these posterior teeth, the overbite will improve because the teeth will be coming together sooner. More importantly, when we push down on the anterior teeth, there's going to be a reciprocating force upwards in this region here. So we're definitely going to want to have very robust attachments on these two teeth here. We're also going to want to build in extrusion. There's not a whole lot of extrusion on those teeth here. So in orthodontics, they have what's called the reverse curve of speed wire. So it's a wire that actually looks like this to exhibit the right amount of forces to level the curve of speed. Well, how do we build that in clear aligner therapy? We have to extrude these teeth here. So typically we'll use this tooth here, keep it at its current position. This is not going to be extruded or intruded. These will all be intruded, the lower 3 of 3. These two teeth will be extruded. This one here is not going to extrude because there's no tooth behind it to anchor. We'll keep that one in its current position, at least from a apical incisal or apical occlusal dimension. So I would extrude these 1.5 millimeters, more or less, and intrude these even more. Create a reverse curve of speed. So when you're done, this should be the highest point. These should be below. Everything 3 to 3 should be below it. These should be above it. I say this should be the highest point. It should be the highest point from lower 4 to 4. These two be slightly above it. This one stay there. Do the same on both sides. Again, in order to create that extrusive force, you're going to need 4 millimeter rectangular attachments beveled to the gingival and have them as occlusally positioned as possible. The higher up the attachment is on the tooth, the farther away it is from the flexible aspect of the aligner, the more engaged that attachment is going to be with the tray. So I would make those changes. This is definitely more of a patient alignment case than it is how do we do it. So if the patient's on board with not considering orthognathic surgery, have a conversation about the anterior recession possibility, have a conversation that the deep bite's probably going to end up, if you got there, you'd be doing very good. I do like the bite turbos or the bite ramps on the upper interiors. That helps to put an intrusive force in the lower teeth. Make sure the patient knows about that. And then fixing this crossbite here, you're definitely going to want to add a rectangular attachment on the buckle here. What that attachment does, it helps to hold the tray on more securely on this tooth so that as it's being jumped, as the crossbite's being resolved, you're getting a better situation there. But I would let the patient know that this problem biomechanically is not ideal. Sometimes you leave them there and you just work out the occlusion when you're done. But this patient's going to be in trays long enough. I really see no reason not to try to do it. Towards the tail end of treatment, if we need to bring in some crossover elastics, I'm happy to discuss that with you. Essentially, you put a button on the lingual of the upper 7, a button here on the lower 7, and you put an elastic on the 2 that the patient wears. That helps to correct the crossbite. So that's about it. Definitely a hard case, but one that, with your experience and our continued conversations, we should be able to get this patient to a very happy place. Definitely a Carrierre case. We got to bring out the big guns to help solve this sagittal discrepancy. Let me know how it goes. Take care.